So in terms of future directions and sort of recent developments, I would say one of the things that it's important to not miss are people who have isolated liver metastasis, because these patients can occasionally be cured by resection. And so we know that 20% of all colon cancer patients present with stage 4 disease, and a third of those will have isolated metastasis to the liver, and 25% of those will be resectable. And if they go for resection, their 5-year overall survival can be 40 to 60%, and that's vastly different from our, from our metastatic patients overall, where the 5-year survival is 10 to 15%. But we have to choose these patients very carefully, and so in general, the surgeons will think about operating if they see someone who has less than 5 liver metastases. None of them are larger than 5 centimeters, and of course, no extrahepatic disease. And really the most important thing is to have a multidisciplinary tumor board where you're involving your medical oncologists, your surgeons, your radiation docs, and looking very carefully at the scans. Now, this was a report that came out last year about the duration of adjuvant chemotherapy. This was the IDEA trial, so stage 3 colon cancer patients who were then randomized to either receiving our standard 6 months or 3 months. And it was truly, an amazing effort where they combined 6 trials that had all been started, and are looking at almost 13,000 patients. And of course, the reason being that, if you could do a shorter course of chemotherapy, you could really reduce some of the toxicities, particularly neurotoxicity with oxaliplatin. And when the data came out, and when you just look at the entire cohort, you could not prove that 3 months were non-inferior to 6 months, but when it got broken down by T and N states, it became clear that those that have lower risk disease, meaning T3 or N1, they appear to do just as well with 3 months than as they did with 6 months. If you, however, had T4 or N2 disease, it looks like 6 months has slightly better outcomes. So I would say this is sort of still being debated within our community and exactly how to interpret this, but many are already adapting giving 3 months to your patient with a T3N1 disease, and clearly lower grade 3 neurotoxicity for the patients who got 3 months. And then recently, we have also been looking at left-sided versus right-sided location of colon cancer, and we've known for a long time that right-sided tumors, they tend to have a worse prognosis. But we have only recently found out that in our cases where we think about combining our EGFR monoclonal antibody, meaning our cetuximab or panitumumab with chemo, which we would only do, of course, if our KRAS and NRAS genes are not mutated, that in the right-sided colon cancers, they just do not seem to benefit from the EGFR monoclonal antibody, while the left-sided cancers can have significant benefit. And so this has now led to a recent change in our guidelines that we should really reserve this therapy for our patients who have left-sided tumor locations, and of course combine with chemotherapy for the maximum effect. And then in terms of experimental therapies, we know that about 5% of colorectal cancers overexpress the HER2 protein. So of course, well known in breast cancer. And this report that came out just last month, and when you use HER2 targeted agents, you can see response rates of 38%. It's really, pretty remarkable. And then BRAF mutations, which we find in about 5 to 10% as well, have always been associated with a poor prognosis. And these patients can progress very rapidly through our standard chemo treatments. But if you combine the EGFR monoclonal antibody with irinotecan and a BRAF inhibitor, they were recently shown to have response rates of 20%. So stay tuned for more info on these therapies.